talk briefly about breast cancer. There are two genetic tests that are commercially available. One called the Oncotype DX, one called Mammoprint. I'm going to give you a case study as to how we use these analyses. This is a 43-year-old woman with a 1.4 centimeter tumor, probably found on a mammogram, premenopausal. This is an invasive ductal carcinoma, which is the most common form of breast cancer. Small tumor, favorable features. The tumor expressed estrogen and expressed progesterone, which typically gives a woman a better prognosis. It was HER2 negative, also gives someone a better prognosis. A grade 2 cancer, intermediate grade, and had no lymph nodes. So we can model that patient's likelihood of reoccurrence and benefit online. So if you look at her and model her online, 73 women out of 100 with her characteristics are going to be alive and cancer-free at 10 years. Pretty good. 25 out of 100 will relapse. If you look at the benefit by taking chemotherapy or hormonal therapy, out of that 25, 9 will benefit by taking a pill. An additional 12 will benefit by taking chemotherapy alone. Because the two aren't additive, if a woman elects to take chemotherapy and hormone therapy, 17 out of that 25 will benefit. That sounds pretty good. The problem is, you don't know whether you're in that 73 who's going to be doing well without anything, or whether you're in that 17 who would have gotten benefit. You would have had to have treated 100 patients so that 17 will benefit. Look how we use this assay. When you take her tumor and you model it on an Oncotype DX analysis, look where she writes. Her reoccurrence score is 1. Her likelihood of reoccurrence at 10 years, 4% by taking a pill. This woman has an exceedingly favorable prognosis. You would never offer someone like that chemotherapy, ever. That would be malpractice. She's going to do great by just giving her a pill. She's going to do very, very well by just giving her a pill. So what do? That test that cost us about $3,000 or $4,000 saved her insurers, saved her employer ultimately, and saved society about $20,000 to $30,000 in chemotherapy costs, maybe more. Similar patient, 44-year-old woman, a 1.1 centimeter tumor, premenopausal, favorable features, ER positive, PR positive, HER2 negative, grade 2. Very much like the first case I showed you. When we model her, in fact, we see a similar likelihood of outcome. 73 out of 100 are going to be alive without no therapy at all and free of cancer, and about 17 out of 100 are going to benefit by taking chemotherapy and hormone therapy. But when you do her Oncotype DX analysis, what do we see here? Just the opposite. Her score is around 50. Very, very high, exceedingly high. When you model her out, she's got about a 33% chance of reoccurring in 10 years. This is somebody we're going to give chemotherapy to, right? We're going to be aggressive with her chemotherapy because we know that taking a pill is inadequate for this woman. And by giving her chemotherapy, we can decrease her risk significantly, at least by half or greater. So this is how we're beginning to use these genetic analyses today to predict how someone's going to do with their disease.